Good afternoon, and welcome everybody to the third day of the Observatory Venice Summer School for 2021. Welcome back to those of you who joined us on Monday and on Tuesday, and welcome to those of you who are joining us for the first time today. This year, the Observatory Summer School, like last year, cannot be done in the way it is usually done on the beautiful island of San Servolo in Venice, because of the circumstances that we all know and live every day. However, we have found this new way of connecting with you and discussing the very important issue of digital health as we are progressing through the pandemic and for thinking about how we can capitalize on it after the pandemic and for the future. For those of you who joined us on Monday and on Tuesday, you will know that we've had very interesting discussions on a range of issues related to digital health. So on Monday, we looked at the scope of digital health, its development and evolution over the years, and the challenge of implementation. And yesterday, we focused on information from information technology, meaning how digital health tools can help us for decision-making in policy and practice with information, and what the different stakeholder perspectives tell us. About challenges and opportunities. And we saw throughout the days yesterday and on Monday that there was a lot of interest also from the audience on a number of issues such as trust between stakeholders and particularly among citizens and patients, but also this idea of fragmentation of data and the importance of having a clear and sufficient infrastructure across the board. Today, we have a slightly different focus. Today, we're looking at the way digital health tools are actually transforming healthcare, including the increased use of digital tools throughout the pandemic. As we heard on Monday, and for those of you who didn't, perhaps a short recap. Clearly, European countries were at a different point with digitalization in their health systems before the pandemic, but what we saw across the board was an increased use of digital health tools to treat or to, let's say, deal with the pandemic at different levels. Today, we're focusing on healthcare delivery, like I said. And as many of you will already have experienced, the pandemic actually moved digital health tools when it comes to the delivery of care from this nice to have notion in many contexts to absolute necessities, exactly because of the fact that in-person contact was not necessarily possible or was actually actively avoided. So what we're going to do today is we're going to take a first look during our keynote speech at European level initiatives from the European Commission, and then focus on experiences from 3 different countries. We have a very, very distinguished group of speakers with us today. It's an honor. We have Joanna Gligor from the Commission. We have Björn Weiss from Germany, Enrique Delgado from Spain, and Katrin Trunner from Austria. I'll introduce them a little bit more as their turn comes throughout the session. And the structure of the session is similar to those of Monday and Tuesday for those of you who were here with us the past few days. So we're going to start with a short keynote presentation from Joanna, followed by spotlight presentations from our other 3 speakers. After each of the presentations, we will take only clarification questions, and then we're going to have a short break. After the break, we will come back with a panel discussion among all our presenters, and that's where we will take more substantive questions also from the audience to discuss and think about how we move forward. For your questions and your active participation, the main or the only tool available given the circumstances is the chat box. You will find that, as you all know, Zoom by now very well, bottom right. And please give us your input and your questions throughout the session in the chat. My colleague Florian Tiller will be moderating the chat today and make sure that your questions also reach the speakers and the panel throughout the session. Before we begin, 2 points of information. First of all, our school director, Reinhard Busse, will be joining us later today to join the panel. So we will have his insights and his input as well. The second one is that we have a couple of channels for dissemination. So if you want to tweet about interesting things that you will hear today, please use Twitter. Our colleague Annalisa Marianecci will copy the Twitter handles in the chat for you to use if you're interested. And also, if you missed Monday and Tuesday, you can find the recordings of the previous sessions on our YouTube channel, the Observatory channel. Don't go now, because now we need your attention for this session. But later, you can always check out. And then as the school progresses over the week, the additional sessions will be added to the YouTube channel for everyone. Okay, and I think without further ado, we can move to our keynote presentation for today. And it's an honor to welcome Ioana Gligor, who is the head of unit for digital health and European reference networks and the Director General for Health and Food Safety of the European Commission, DG Santé. Ioana brings a long experience with a European institution, but also experience from the national setting. So I think it will be very interesting to hear your input. And Ioana, I think you will show us what the Commission has been doing to enable digital health for now, but also for the future. So over to you, the floor is yours.
Yes, thank you very much for this opportunity. I will speak about the European Health Data Space, but before going into the discussion about the European Health Data Space, I would probably take also the opportunity to mention the fact that the current crisis has produced actually a kind of change, a profound change in the way that the digital relations are structured in Europe, and this has also impacted on the health side. And what we are witnessing very clearly in Europe, it's a strengthening of the relations between the member states in the area of the digital health. And for instance, we have been working with the member states since March last year in around 300 online meetings in order to set up the digital COVID certificate, and also in order to set up the contact tracing and warning apps. And this was quite a lot of work, but also has produced quite impressive results, I would say. So I think basically these elements will allow us to continue also in the context of the European Health Data Space with the new impetus on which we can build upon. So if we go to the next slide. On the European health data space, I would like to underline that this would be based upon the Data Governance Act and on the data strategy, which aims at building and setting up several data spaces, health being one of them, along with others like mobility, finance, etc. Basically, what we are aiming to do is to support the setting up of the European health data space with the legal proposal and also with infrastructures, and also to work in the context of the several data spaces in Europe. If we go to the next slide. So what are the challenges for the EU? What we are seeing now, basically, it's a limited sharing of data for the healthcare, with the limited control of patients to access their health data, which entails basically a lot of costs and problems related to the and burden on the healthcare system, also insufficient exchanges and limited interoperability. We are also witnessing, in the context of the mHealth and telehealth, quite an uneven landscape. As I said, the crisis has produced profound mutations in the sense of new legislation, but still the landscape remains quite fragmented, especially between the countries, but also sometimes within the countries. Also, the reimbursement of these digital health services and products remains limited. On the reuse of health data for research and policy making, we are also basically witnessing problems related to the fragmentation, to the low reuse, to fragmented digital infrastructures, which also impact on the issues related to the artificial intelligence. So basically, we are working in order to address all these elements through the legal proposal and infrastructure, both for the primary, secondary use of data, data quality and capacity building. And what you see on this slide is basically the main areas of work, especially in the for the legal proposal. For which, by the way, the public consultation has been finalized. If you go to the next slide. Thank you. So the European Health Data Space will build upon the current legislative framework with the GDPR, the Data Governance Act, the AI regulation, the Cross-Border Healthcare Initiative, but also with that upcoming Data Act. And as I said, it aims to address the issues related to the use of data for healthcare, the digital health services and products, and also the reuse of health data for research policy making, regulatory purposes, and the support for the use of AI in healthcare, in health. We go to the next slide. Thank you. Next. So I will not insist a lot on the points we are seeing here, but the main challenges are related to the access of patients to their data and also interoperability and the tools of infrastructures for doing this. Go to the next one. We have already in place a new wide infrastructure with 7 member states which are sharing patient summary and e-prescriptions, allowing basically the patients to share their information with the healthcare professionals when they are traveling to another member state in the language of the healthcare professional. We hope to have additional member states up to 8. I'm not really sure that we will really reach 8 this year, also given the pandemic. But in any case, the number of exchanges is clearly growing. And most of them are between the neighbors. We are seeing also here, indeed, we will also add additional services like images, lab results, discharge letters, and the services for the patients to access their health data. And if you go to the next slide, thank you. A strengthening of interoperability. The Commission has adopted the electronic health record exchange format, and we aim to take this forward in the context of the European Health Data Space. Next slide. So this is a little bit the explanation of the previous work. So the member states have been working on the electronic health record exchange format, but the European Health Data Space will offer additional opportunities in this area. If you go to the next slide. On the digital health services and products, as I said, the crisis has produced a complete change of the landscape, and we are clearly seeing issues related to the reimbursement. And as you may know, we are evaluating the Patients' Rights Directive with an open consultation, which is basically was ongoing until I think it has closed very recently, with issues related to the interoperability, the possibility for the patients to share their data with the healthcare professionals in the context of mHealth telehealth, to share their data from devices with the professionals or other entities of their choice. Also, a lot of divergence in terms of interoperability, labeling, and certification. The medical devices regulation has brought a certain uniformity, but still on the mHealth and especially on the mHealth side, the thing remains quite fragmented. And also there are issues related to the data privacy and liability. If you go to the next slide. On the secondary use of health data, Here, indeed, we are aiming at supporting such a reuse with infrastructure, trusted governance, and clarifying the rules, basically, for granting researchers, policymakers, and industry access to the health data across the EU in a trusted way, with a trusted governance, with a trusting infrastructure, in an interoperable and digital format. If we go to the next slide. So here you are having some ideas about a possible infrastructure. If you go to the next one, with a pilot project that will start in 2022. And the next one, I will try to accelerate a little bit because I don't want to keep you very long. So in the context of the legal proposal, we are now we are working on the impact assessment. We have finalized the public consultation, and we are aiming at having the legal proposal at the beginning of next year. If we are going to the next slide. There are important budget for the digital health, and I would like to underline this. This comes both from EU and national funds, allowing for the investment both of national and EU level, with Recovery and Resilience Facility, ERDF, European Social Fund, and InvestEU, and also the EU level investment supporting the work at EU level, EU for Health, Digital Europe program, and also Horizon Europe, supporting this kind of investments and connections at EU level. If you go to the next slide. So maybe just I was mentioning before that the pandemic has increased the exchanges. So the digital COVID certificate, on which you will have a special presentation, and I will not insist very much on this, it's a very clear example of strength and collaboration, with eHealth network being at the center. So this digital certificate allows for issuing vaccination, testing, and recovery certificates, and allows for facilitating the travel in Europe. If you go to the next slide. This is basically a presentation of how the system is articulated. But again, as I said, tomorrow my colleagues will present additional details. If we go to the next slide. Here you are having basically a schema how this can be articulated. We can go to the next one. The guidelines and technical specifications now in implementing acts are public, are on the site of the eHealth network. The next one. And we are now working on basically equivalence decision with the third countries in order to allow basically the travel and the free movement also of third country nationals coming to Europe, or of European goings to other countries. Next slide. So here you have a little bit of an overview of what is going on in terms of the working within and within the EU and also with the third countries. And if we go to the next slide. Yeah, I think basically some of the lessons that we can learn from the digital certificate is that there was support from the public, that there was a political will, and also very strong legal basis, and it has leveraged into other European initiatives, including, for instance, it has offered some inspiration for EID, one of the latest evolutions. Go to the next one. Maybe we can jump to the next point. So the contact tracing app, it's another element that has been brought by the crisis. Again, I will not insist very much. We have been working with the member states since last year with a lot of discussions and meetings. And if we go to the next slide, the discussions were focused on legal, organizational, epidemiological, and technical aspects, involving member states and also other organizations like ECDC and WHO. If we go to the next one. Here you have a little bit of how does it work. Basically, the contact tracing apps allow the people who are infected to notify the people that they were in contact with in a or anonymous way, and be able to let them to inform them about the fact that there may be a risk of being contaminated with COVID. Go to the next slide. The state of play basically is that we have now 19 member states which are live, especially in the decentralized system, and also the 2 member states which are in the more centralized systems, and other which are not connected. If you go to the next one. I would like to thank you very much, and I remain at your disposal for further questions. Thank you.
Thank you very much, Ioana, for this very informative presentation. I think you expertly linked all our topics, from the data issues that we talked about the past few days over to the healthcare provision today, and with the outlook on what your colleagues, you're right, will help us with tomorrow. On tomorrow's session, we have a specific slot for the COVID-19 certificates because of increased interest in the topic. I think I don't think we have any clarification questions, but Florian, you have a better overview of the chat. Have I missed something? Is there something we need to clarify?
Yeah, good afternoon, everyone. And thanks, Dimi, and thanks, Ioana, for this wonderful presentation. In fact, Dimi, you're right. There hasn't been any question on clarification yet in the chat, so it might be coming up later then.
Okay, I think that was a lot of content, and Ioana, with your permission, we will share the presentation with our participants so that they can go back and look at the individual bits in more detail. If we still have you for the panel, I have a couple of questions, particularly focusing on the issue of healthcare that we're looking at today. If we miss you, we'll do the best we can with what you've talked to us about already, and with the slides. I think in the interest of time, we move on to the next presentation. Thank you once again, Ioana. And I'm very happy to welcome Dr. Björn Weiss from the Charité University in Berlin. It's the medical university. Björn is a consultant in anesthesiology and intensive care medicine. He's also the head and coordinator of Tele-ICU at the Charité Universitätsmedizin Berlin, which also links with more than 30 centers in Germany, I read. And you're also part of the national COVID-related ICU expert group at the German Public Health Institute, the Robert Koch Institute. Björn, you're going to talk to us about a very interesting initiative that you started in Germany before the pandemic, actually, and how maybe it blossomed, let's say, during the pandemic. But I'm not going to take too much over from you. I'll just pass the microphone to you. Floor is yours. Give us your expertise.
I hope I can use the next 10 minutes to tell you something about telemedicine, and to tell you what we could actually offer the pandemic. You said it right. I'm an intensivist, actually. So, and you know that intensive care was a big topic in the last year. So I would not say that the pandemic enhanced our project. I would rather say we could offer the pandemic something, or we could offer something for pandemic management here. Okay, so let me start very fast to show you my conflict of interest. The most important thing is that today I got no fees, no honorarium, and I have no conflict of interest, but I'm part, as you said, of several guideline committees, of several advisory groups, and I'm also involved in ESICM activities. So the most important question, actually, when you want to understand telemedicine and the impact of telemedicine in COVID-19, is probably what are the intensive care challenges we faced during COVID-19. And when you remember the beginning of 2020, the potentially most often asked question in Europe was, do we have enough intensive care beds, and do we have enough ventilators? And what we found out a little bit later is that it's not so much about the intensive care beds, but rather about the people. the people running these beds, and it's not like any kind of people, but highly qualified people. So to actually make intensive care work and to treat these especially sick patients, COVID-19 patients that require assistance of ventilation, whether it's invasive or non-invasive, that requires a multi-professional team. It requires nurses, it requires doctors, it requires allied healthcare professionals like respiratory therapists, etc. And all these people are necessary in quality and quantity to run intensive care beds. And this makes it pretty clear what problem we really ran into at the beginning. And if you want to have this a little bit more elaborated, then I would recommend you to read this viewpoint from the JAMA that was published at the very beginning, talking about the early experience of the pandemia in Lombardy, Italy. A friend and colleague, Maurizio Cicconi, published this together with Giacomo Grasselli and Antonio Pesenti from Milano, and they were the first ones actually in Europe to face this very intense surge in critical care cases. And what they told us is it's not so much about the capacity in a region, but it's more like the very local surge in patients. It might be that in Bergamo, people are running out of bed, whereas in cities next to it, there might be still beds available. And so Maurizio Cicconi stressed very much that the network and the pre-existing structures are extremely important to equally distribute patients in hospitals. So now one big problem is, and let me explain that to you, that patients suffering from COVID-19 usually would be treated in so-called ARDS ECMO centers, which are level 1 centers, so these tertiary care centers that actually provide maximum care. It's called, I think, level 3 in the UK, it's level 1 in Germany, and so everyone has his own terminology there, but I mean there's these centers, that university hospitals that provide maximum care. But if we look at the total capacity of intensive care in a country, we usually have also medium, large hospital and small hospitals, and they make a majority of intensive care beds. If you want to look at it from the German example, we are doing a lot of intensive care intensive care medicine. We have more than 2.1 million ICU cases per year, and we have more than 400,000 ventilations per year. And these data are from pre-COVID times. And if you look at the large hospitals, they only treat about 1/3 of these patients, right? So actually the majority is treated in small and medium-sized hospitals. And as I said, usually those patients were treated in the big ARDS ECMO centers in normal times. And now suddenly our total ICU capacity was mainly coming from small and medium-sized hospitals. And the question is, how can a region actually be effective in managing COVID? It's actually only possible if you rethink acute medical care, as the Nuffield Trust has done it before. And I think that's a very nice publication we can discuss later, which is also pre-COVID times. We need to shift from this all or nothing principle. That's what the authors write. And we need to go towards a more modular care, and we need to support local services by other hospitals, in particular the specialist centers. So, and in Berlin and Brandenburg, the situation was actually that we have a high density of hospitals, but we also expected a high case number. Yeah, we were proven to be right. We had an existing ARDS ECMO network in the university hospital here at Charité. And we also had an ERIC telemedicine network, which was just established at the time point when the pandemia started. What is the ERIC telemedicine network? It is actually a network that has been established a couple of years ago. And the idea of the telemedicine in the network was to do what the Nuffield Trust actually wrote, to provide modular care and to implement evidence-based medicine and to prevent post-intensive care syndromes, so long-term impairments deriving from critical care that would by far exceed the 10 minutes. So I'm just skipping over that. And we also had the post-acute care treatment by ICU follow-up clinics, which is also extremely important for COVID, especially for long COVID, if you have heard that. So long-term consequences patients are suffering from. Yeah, but we're focusing on number one now. So we use the telemedicine network. And how does this telemedicine network look like? It's actually a model that is called round and response service. So we are available 24/7, 365 days per year. And we have a couple of remote clinics. We already had that before COVID, where telemedicine cards are located and where experts from Charité can beam into these cards and give advice to local physicians. So how does it look like in practice? So this is the project this is a very brief slide just to tell you what we've done before. We've done a cluster randomized trial in a step wedge design that was called Enhanced Recovery After Intensive Care, ERIC. And the ERIC project was running for 25 months, and we had a control and intervention condition. Intervention was basically telemedicine, control condition was conventional analog care, if you want so. And we had 11 centers and specific predefined crossover points where people were getting the telemedicine. And the trial has been finished, and we did over 10,000 consultations in the time. That's an additional information I just give you as a little side information to understand it. But I want to show you this. This is more important. I want to show you how the telemedicine actually looks like. And I just have to switch that off. Yeah, so this is actually what we're doing. We are working, we are working in a tele-ICU, which is a designated workspace at Charité in a so-called hub structure where a doctor from Charité, an intensive care specialist from the ARDS ECMO network is sitting. And this specialist is here using a dedicated IT infrastructure to beam into robots. And the robots, you will see that here, are standing in the remote sides of the hospitals, and they are like self-driving devices comparable to maybe machines you can use in the household also to drive around, you know, these iRobot things that you can use to the vacuum cleaners, etc. The technology is pretty much the same. So it's actually a robot that can be remotely controlled and is not able to crash into anything. And here is our patient, which is a simulated patient in this case. And here is the remote side team. They are treating the patient, and the physician is here. Now we change the perspective again, looking at the doctor and the nurse and the patient and the ventilator settings, and is consulting this patient. So the patient here is simulated to be extubated soon, and you can see that the resolution and everything is very high. So the audio video communication enables us to be really part of the remote team. So after the consultation is finished, we have, oh, this is also interesting. We can really, with the technology, look at ventilators, look at monitors in the room. And, you know, our eyes here in the hub are actually, seeing the same or even more than people on site sometimes, because the resolution and the zoom, the optic zoom is very good. So this is our tele-ICU, and this is the system that has been established. And now it's interesting to understand what happened in the pandemics. Okay, here now the patient and the doctors are waving goodbye. What happened actually, we developed something that is called the Safe Berlin concept. And besides a containment strategy and defining specific hospitals where COVID patients are treated, we defined hub hospitals that were able to provide telemedicine, which was basically the Charité ERIC tele-ICU, and level 2 centers, so medium-sized hospitals that were able to treat those patients with telemedical support. We established a transportation system together with the fire department in Berlin and a telemedical system on the basis of ERIC that was scaled rapidly to all COVID ICUs. So This is Berlin. This is the shape of Berlin. This is level 1, 2, 3 hospitals. Level 3 hospitals are those that were kept COVID-free at the beginning. You see, it's not limited to one hospital company, but it's affecting really everything, the private sector, the public hospitals, the emergency hospitals. And we put all these machines here in the hospitals, and we connected them all to the Charité campuses. This allowed us to really implement evidence-based medicine in these critically ill patients and make sure that every patient, regardless where he was treated and by whom he was treated, that he had the connection to the level 1 ARDS ECMO center, and allowed us to individually allocate resources to these patients. So during the first wave of COVID, this is only that part, we did more than 3,500 consult calls, and by now we nearly tripled that. So we came over 10,000 consult calls again in the second and third wave. We have 28 regional clusters connected to the hospitals. We have 9 specially trained intensivists that provide this 24/7 service, and we do up to 60 consults a day. And as this was pretty successful and the robot supported the local teams, and the robot also connected the teams with each other, in the meantime, we also scaled this on a German national level, and we are now also doing international telemedicine in Tashkent, Uzbekistan, and in South Africa, where the variants of concern are at the moment causing another really bad wave. So we're working together with hospitals there and also, explaining them what to do. So, and I could tell you much more, and you see that the topic itself and the content and the background is pretty dense, so there's a lot of things to say, but I think it's a nice example for digitalization. And of course, it's not only me, I'm part of the team, I'm part of the machine room if you want so, but Reinhard Busse is also part of the consortium, and we have a lot of really wonderful people. Claudia Spies is the head of our department and the head of the program who led this, and we're seeing where the pandemia actually led us in this digital project, and I hope you got a good impression. Thank you very much.
Thank you very much, Björn. I'm sure we'll come back to this and the bits that you could elaborate more on during the discussion later on, but I think there might be clarification questions given also the technical nature of the presentation. Florian, over to you. Any questions from the chat that we need to ask Björn at this point?
Yeah, thanks, Dimi, and thanks, Björn, so much as well. In fact, there is a very good question that just come in the chat, and Anita actually has been asking whether Björn could be so kind and say a little bit more about how the robot actually functions, concretely how it collects the data and which type of data it is collecting. I guess you could go on this for a while, Björn, but maybe just in a few words would be great.
Yeah, that was actually the shortest presentation ever I gave on this project, and it was a really broad scope because I started at the beginning. So when we started with that in 2016, and now it's 2021 and we scaled it. But the robot itself, so there are 2 different technical options we are using. One is a robot, one is a car. The difference is one is driving autonomously, so we can steer it from here. The other one has to be pushed through the rooms. The good thing is, this is actually, from a data protection perspective, it is a pretty good system, as it is a peer-to-peer, end-to-end encrypted connection that actually does not collect any data. It is just actually, allowing us to have a video call, an encrypted video call between 2 sides. The data that we are collecting, we collected through a dedicated platform, a platform that is accessible from the remote side hospital and from the hub hospital, because we don't share an electronic health record with most of the hospitals. So it's actually necessary for us to find some kind of basis where we also document our medical stuff. And we do this by a especially designed critical care ERIC platform. But the robot itself does not collect any data. It's just working with cameras.
Excellent. I think we come back to this, Björn, also because I would like to ask you when the time comes for the discussion about the evaluation that I know you've been doing as part of this project of the whole idea.
Sure.
But that probably is a little bit of a longer answer, and we come back to that. We come back to that on the discussion. I think we thank you very much for now. We move from Germany to Spain. And it's a great pleasure from Spain to welcome Enrique Bernal Delgado. Enrique is a frequent colleague of ours here at the Observatory. He's a senior scientist at the Institute for Health Sciences in Aragon, and he leads the group of data science for health services and policy research. And Enrique, you've been also involved in a range of projects, also at European level, about how we can make the best use of digital health data. And you have a very clear overview of how digital health was used in Spain during the pandemic in comparison to how it was used before. So maybe you can give us your lights about that in your presentation. Over to you.
Thank you, Demi. Thank you very much for having me today. It's a pleasure. You can imagine that being quite a rich environment on data use, primary use and secondary use, lesser use, though I will comment later on. And being one of the big shocked countries in the pandemic, once we wake up from the shock, so early soon in the process of the 30th of March, we started using the capacities that we had in terms of IT technologies and data sharing and so on, to get the most out of what we had. Basically, just let me sum it up. We increased dramatically the number of teleconsultations to avoid face-to-face encounters with the health system. Our health data folder, so that the individual one, the personal one data folder on our medical records, increase the number of capacities, for example, individual information about how to do things, the prescriptions, so in particular to chronic patients, prescriptions was granted irrespective of the status. Yes, when they expired, they were prescribed again naturally, so the patient was able to access remote consultations every single day. Doctors were consulting among them. So for example, primary care physicians, consulting specialists, citations were able, telestroke and telepsychiatry consultations were present. In terms of e-health, also there were many options to get the way. So in the end, the landscape changed so dramatically in a few weeks that we end up saying, well, take advantage of the environment that we have and see how to get the most of that, to care people properly. Well, I must say that now people is, let's say that is now more reluctant, because in the end, the 5 or 6 waves of the pandemic have in the end make the population adapted to the new situations. They don't like much now to go to teleconsultation. They want face-to-face, and there are now a big of a national debate on how to restart primary care, particularly primary care, as soon as possible, face-to-face. But maybe the good thing is to know where we're coming from. So to understand, unlike what has been presented in the first presentation, so a very, let's say, specific scope, let's look at a more broader perspective, which is a national one, which is the case that I want to comment to you today. Well, in the end, we have to understand that we were in a good position 1.5 years ago, because we start off quite soon. 90s in the past century, and basically the big developments were happening that decade. You must think that we are a federal country, and you have to coordinate 17 regions and the civil servant mutualities. So the judiciary, the army, and all the civil servants are covered differently to the general population. So we were talking virtually all the population covered in the country. Well, the digital health strategy in that sense in the early 90s had to be based in a coordinated process, because in the end you have 17 different regional authorities, and you have to make decisions together, because we do have this interterritorial council board, which is the high level body for making decisions. So once we decided about how to move forward in the early 90s, well, we started, implementing digital health in all the regions. We counted with a number of advantages. The strengths of our system, for example, virtually all residents in Spain, even undocumented migrants, are registered to a primary care physician acting as a gatekeeper. Most of the providers are integrated primary care plus hospital care, and most of them are public, and so are obliged to implement decisions made at high level. Well, we had in the 90s, but even before, but we start off collecting data in a systematic way using interoperable mechanisms and fairly high quality data collection. So in terms of coverage, for example, all the population is covered. In terms of the depth of the information collected, clinical information, for example. So in the end, we account with a number of advantages at the time. So once we made the decision in Spain to go further in terms of implementing digital health in extents, we counted with a well-rooted system to do so, and we took the advantage. Well, this is the very basic cornerstone of the development. So we do have a single ID for all the country. This is my health record card. So this is myself. And as you can see in the card, we do have two numbers. The first one starts in AR from Aragon, is the regional number, and the second one, BBBBBBF7, so is the national one. So, and I do have a single number for the whole country. And as you can see on the map, if I want to move towards another place in the country, doctors are entitled to get my records. So using a certificate, digital signature for sure, but they are entitled to get a summary patient record and also the discharge record, and also the patient, the images, the radiology record. So if I want to, to get dispensed in a pharmacy, in a retail pharmacy elsewhere, the pharmacists taking my card is able to know what are the prescriptions I have active at the point, and they can dispense me and reimburse my region. But also I have entitled myself as citizen. I can control my own folder, my health folder, and change the permissions. So if there are some record I don't want any doctor to look at, I can cancel it, and so on and so forth. So this is the very basis of our system. Every single citizen in Spain has their own ID and is able to share data. Okay. What is the actual use of digital tools in Spain beyond what we've done in the country? Well, at region, on the left-hand side, planned, implemented, ongoing, actual use is very much social media, mHealth, and e-health services provided at regional level, and also at national level, e-health and social media services. And this isn't likely, but you might find some testing and piloting at regional level that is promoted to be part of the current use, actual use at regional at national levels. Some piloting is made, for example, to mobilize, mHealth monitoring in patients, fragile patients, So to follow up, at palliative care and nursing care, and then this has been tested in a region, and they once tested and evaluated is promoted national level, promoted at national level or promoted at regional level for current use. When it comes to testing and piloting, though, the vast majority of the experience in Spain is at a provider level, hospital level, and all of them are promoted to be, used as a regular use of that. And then you can find some informal use as well. So the point for this slide is, well, we have rooted at this point in time a lot of mHealth, a lot of eHealth, a lot of social media. They have been used in the COVID pandemic and are prepared to be COVID in new needs in the future. But many of the things that are being done in the country are at testing and piloting level and not yet been passed towards the current use. Well, let's go for an external evaluation of our system. If we take this report, Thiel and collaborators on smart health systems, Bertelsmann Foundation found that Spain, for a number of indicators, policy activity, political strategy, technical implementation and readiness, and actual use of data, is on top of the countries studied in this report. And they say that the key points of our success are these 7 that I'm highlighting here. In Spain, there was a political will in the 90s, and there was a earmark budget specific to the development of the technology. There was a national strategy with wide agreement across the different regions, the different regional authorities, capacity building measures in place all over the country and over the years, in terms of human resources skills, but also in terms of IT development, security and privacy by design, and actually population trusts, which is very interesting. ICT standardization efforts coordinated by national entity, the Ministry of Health, with the agreement of all regional authorities, semantic and syntactic interoperability efforts coordinated by the same national entity, and data linkage facilitated and operational, which makes much more easy to move forward. When it comes to the challenges, this is my last slide. In the post-pandemic area, thank you, Dimi, to show up. Well, technological infrastructures are set up, as you may have seen. So my car is being used everywhere in the country. But services are unevenly used, unfortunately, particular clinical services associated to the knowledge the doctors do have. And far from routine medical use for telemedicine and health, although there are many experiences, as I mentioned, and there are many country experiences, but for clinical use are unevenly used, unfortunately. There is no appraisal in or assessment of the impact of telehealth. There is no appraisal in or assessment of mHealth, not even a framework to assess it. We are lacking a clear strategy on secondary use data, and we are lacking a clear strategy on artificial intelligence utilization leverage. And that's all. Thank you very much.
Thank you, Enrique. This was illuminating. I think we'll come back to the evaluation, and I'm glad that you brought it up later in the discussion. But now we go to Florian briefly, because I think there might be a clarification question or two. Florian, over to you.
Thanks, Dimi, and thanks, Enrique, here as well. Yeah, one quick question for clarification there for you, Enrique, which is on the ID numbers that you were showing for the patients in Spain. So do people in Spain actually have 2 ID numbers, one for the regional and one for the national level?
No, actually are the same, are intertwined. So is one for the region, but is linked to one. So every single citizen has just one number for nationwide experiences on digital health. So it's yes, twins numbers.
Very clear, thank you.
Okay, thank you very much, Florian. I think that was it for now. And we come back to you, Enrique, in the panel after the short break. Thank you very much. We move from Spain to Austria. And we have the pleasure of having with us Katrin Trunner, who is a specialist in health telematics, works for the Austrian Public Health Institute, is responsible there for the management of national and EU-funded projects in the field of health telematics and e-health. And Katrin, you are also heavily involved with the Austrian COVID certificate, I think. So give us an overview from Austria about what happened in the past 18 months. Thank you very much. Over to you.
Happy to be here. I hope you can hear me clearly and see my slides. So yes, I'm here on behalf of Alexander Degesager-Marquez, who is the head of digital health and innovation at GÖK. Yes, and I will start with the presentation with a short introduction about our institute, the National Public Health Institute Gesundheit Österreich GmbH, GÖK. For those of you who might not know it, what we are doing, it's established in its current form by federal law in 2006. So about GÖK, very briefly, what we are doing. So we were established in its current form in 2006. We have 3 business units. One is called the Austrian National Institute for Health Services Research. It's the oldest one. It's established in 1973, and it regulates and reforms the Austrian healthcare system. The second one is the FGÖ, the Austrian Health Promotional Fund. It's taken over the task to encourage health promotion and prevention in Austria. So it's also granting funds, which is very interesting to do it in our organization. And then the third division we have is the Austrian National Institute for Quality in Healthcare. So this is the newest division at GÖK. It was established in 2007, and it's responsible for developing, implementing, and evaluating a nationwide quality system on behalf of the federal government. Yes, a few words about digitization in healthcare in general I wanted to bring up here. So what is the current situation? What are we watching at the moment? So we have more and more data coming up and available. There are new data sources, omics, variables, the Internet of Things, and so on. There is, of course, more computing power, and there's also the artificial intelligence and the machine learning coming up more and more and available for us. But there are also some behavioral changes as well. People are learning to deal with devices, new sensors, and also, of course, they're more familiar with the internet. More and more people are aware how to use it. And there are also changing expectations and demands, like the individualization and so on. And the next point you see here, this is also linked to it, the changing role of the patients, the patient empowerment, patient wanting to take over more and more by themselves. So this is very interesting, and there are also some new approaches to care, like to move the healthcare and not the patient. This is something also linked maybe to Björn's presentation, and some new business models are also coming up. So I brought you some few snapshots about Austria statistics and digitalization. The first one is about individuals who have used the internet to access health information. So Austria corresponds very much to the OECD average here, and the Northern European countries are leading this statistics. So you see here Finland, Netherlands, Norway, and Denmark, and so on. The next statistic shows the Digital Economy and Society Index from 2019. You see here that Finland has again the highest score, followed by Estonia, Netherlands, and Spain. Austria is here in the middle, somewhere a bit above EU average. But for the e-health services, we are a bit beneath the average. So you see this as the red column here. So hopefully this will change in the future, of course. And the third snapshot I brought with you is about individuals who have booked doctor's appointments online. It's from 2018, and we are also very much below EU average. You see here this red arrow. So yeah, I'm hoping too that we will be able to speed up this here with our systems that are already in place and will be implemented soon. So about digitization in the health sector in Austria, what services do we already have available? So we have our electronic health record system already available since I think now 7 years. It's called ELGA, Electronic Health Record, Elektronische Gesundheitsakte. I will talk a bit more about the functions on the next slide, so I will skip it here. We have the e-prescription already in place, but only in a pilot function. We have the electronic vaccination pilot now available. We have our 4015 hotline. We have the public health portal, gesundheit.gv.at, where the citizens are able to collect all the information they need in terms of healthcare. We have also some telemonitoring applications and services available, like Herzmobility App Care, also throughout Austria and also on a regional level. There's also, of course, research work going on from universities or University of Applied Sciences, and there are some regional projects and strategies of the Länder and of the social insurance. So about Austria's ELGA, very short, it's because it's the basis of our electronic health record system. It reflects very much the Austrian health politics. We have federal government and the 9 Länder and the social insurance, and they are financing the electronic health record system. First frauds were in 2000, and there was a feasibility study performed in 2006, and now we are the system gone live in 2014. The central components are the patient index and the health provider index, and there are 2 core applications, the e-reports and the e-medication at the moment, and we are piloting the e-vaccination pass on basis of this infrastructure. The idea is to build telemedicine and e-health applications on this infrastructure. And the principle of ELGA is it's a decentralized infrastructure, it's undirected communication, and it's structured data according to international standards. And we have an opt-out regime. So this is a screenshot from ELGA, from the portal, with e-records, e-medication, and the healthcare providers that are currently accessing data and the protocol, the log data. You can also opt out here, so everything is already available there. So now we're coming closer to what the presentation is about, actually, about what COVID-19 has changed in Austria. So, for example, we are now using e-medication as infrastructure for the e-prescription. This is one thing that changed now. We have also adapted the e-vaccination pilot that was already in discussion before, but I think there will be on the next slide more information about that. We have expanded the reimbursement of telemedical treatments in the collective agreements. And also, of course, video consultation was one of the main topics that came up within the COVID-19 pandemic. So physician software manufacturers integrated video consultations into their software. Often it was initially free of charge as an add-on, and after full integration was then subject to a charge. So video consultation is used, for example, for initial consultations, therapeutic talks, discussions of findings, and so on. Then we have, of course, also COVID-specific symptom checkers for triaging mostly. And then there is a changed view of health data. For one of the points is, for example, if Austria's health policy should support health data sharing for COVID research, should it limit, prohibit it? So this was also a very big discussion in Austria. Yeah, about the electronic vaccination pass, I have already said a bit about it. So it gives you information on your vaccinations. It's accessible via the ELGA portal. The functionality after the full rollout should cover the personal vaccination calendar, reminder functions, and so on. But there is, of course, there was an opportunity arising from the COVID-19 experience as well here. So this was the fast tracking of the vaccination pass, because without COVID-19, we would not have been able to, of course, implement it so fast. As I said, it was already planned, but it was not, of course, subject to such a, to do it in such a short amount of time. And we are also, of course, we can use this maybe to also integrate other applications now easily, for example, diabetes pass and so on. This is also already in discussion. And I think COVID-19 has given us now the opportunity to do this in a faster mode. The challenges were the redesign. So we had to redesign the pilot, which was initially planned to do with kids, to COVID, of course. Not all actors who carry out vaccinations had access to ELGA. There also were some data protection issues, sharing of vaccination registry data between ELGA and ministry and so on, about the vaccination documentation for the subsequent data entries for the first and the second vaccination. So those were some challenges. The role of the Länder to make sure everything is in place, and there is the evaluation still pending. So the public health aspect is, if there's a big question also in Austria that was discussed if the government or public health needs to know about the immunization status of the population. So this might be maybe interesting to have in a discussion afterwards. Yeah, but the green certificate, I think we have already heard about it before from the Commission. The digital COVID certificate, we also have it, of course, in place. There are free sources used or to gather or retrieve information. That's on the one side the vaccination certificate, the certificate of recovery, or the test certificate. And we have now also an app available where you can upload the certificate, and it gives you simplified information in a digital and mobile mode. We also have the 4050 hotline, which is a health advice hotline. It's implemented, or it was implemented before in 3 Ländern as a pilot. There was a positive evaluation, and there was then the rollout in all of the 9 Bundesländer in Austria until the end of 2019. The overall goal was to steer the flow of patients to the best possible care options on this 24/7, so around the clock. And during the pandemic, 4015 handles different pandemic response tasks and has become the central point of contact. So there's currently an evaluation ongoing where I'm also part of, and we're doing some interviews and focus groups in order to perform the best evaluation possible. So the level of awareness has increased enormously for 4050. Everybody is now aware of this. But there is an open question about how to return to the core business, because as I said, it was the original goal was to steer the flow of patients to the best possible care options. And now it's more like a Corona info hotline. So this will be one of the challenges. We also have a COVID-19 data platform in Austria, which is to help national and international research community to improve evidence for and increase understanding of COVID-19. So academic and scientific institutions can be given permission to use data sets which are from the EMS, the epidemiological reporting system. And since March, there are also anonymized diagnosis and treatment data of patients with principal or secondary COVID-19 diagnosis. So this is very interesting for researchers, and for data protection reasons, data can only be made available to research facilities after accreditation by the advisory board. So GEC is responsible for the operational management and the implementation of the data platform and acts as administrative office. There's also a very interesting link collection. If you're interested to work with COVID-19 data in Austria and international, you should go and see the information there. And last but not least, we have the Stop Corona app. So within the EU, the focus is, I think, more on voluntary and anonymized proximity tracing apps using the opportunities offered by mobile device Bluetooth functionality. So there was a EU-wide discussion on data storage, if it should be decentralized or centralized. And I think the decentralized approach became the de facto standard, also because Apple and Google joint APA supports only decentralized approaches. So Austria was among the first European countries to offer such a proximity tracing app. It's the Austrian Red Cross app, Stop Corona. It was developed independently by the Austrian Red Cross in partnership with Accenture. So the funding was private, which makes it very interesting that it was developed by private institutions, and it was then presented to the Austrian government for endorsement, and the ministry included it into the government's wider COVID-19 containment strategy now, including funding. So the app is voluntary, but its use is recommended. So we have around 870,000 users, which is approximately 10% of Austria's population. So it's, of course, less widespread than the German app, which is roughly covered 20% of German population. But it's now, I think, too early to evaluate and the use and the impact of the app. So yeah, I think that's everything for now for me. And of course, if there's some question, I'd be happy to answer them.
Thank you very much, Katrin. First of all, for bridging us already to tomorrow when we're going to talk about digital health and research with your slide on the platform, and also for pointing out the important issue of public-private partnerships. Maybe we come back to that during the panel. For now, let's go to Florian. Florian, are there any clarification questions for Katrin?
Thanks, Dimi, and thanks, Katrin, as well. So there are, in fact, 2 questions that have come in from Sutayut. Thank you very much, Sutayut, for those and very good points. The first one would be, Katrin, if you could and you mentioned this, but maybe say a few more words on to what extent the electronic vaccination passport that's been piloted in Austria is actually linked to the EU vaccination certificate. Understanding we will look into this tomorrow as well, but you probably could share some insights. And the second question was why not all actors who carry out the vaccinations had access to the ALGA platform, as you mentioned?
Okay. So the first one about the vaccination pilot, we of course retrieve data from all of the vaccinations, and the certificate is then gathered as a result of all of the data gathered. So it's linked to the EU vaccination certificate. So the certificate is one of the results of the platform of the pilot. And the second question is why not all actors were able to use it. As I said, it was a pilot at the beginning, and we only planned with a very few actors. And there's always the problem with the company performing vaccinations. So we also had to deal with this issue, and also to make sure that those vaccinations are included within the COVID-19 piloting infrastructure. So, yeah, I hope that clears it.
Thank you very much, Katrin, and I think thank you, Florian, as well. I think if there is more substantive interest in these points, then we come back to them during the panel. What we're going to do now is going to take a 5-minute wellness break.
Welcome back, everybody. My name is Reinhard Busse. I'm the director of the summer school, and I will lead you through the panel discussion now. We heard the introductory lecture and 3 examples. And as you remember, we are trying to sort the week a bit in looking into the different aspects of digital health. We looked yesterday after an initial round on Monday. Yesterday, we saw, okay, what kind of information can digitalization produce? Today, we look at how it can change care. And tomorrow, we will be looking at how it can change research. And clearly, we have seen that these things are closely linked. But let's start really with a focus on today's topic, how digitalization can help to change care. And we are all aware that the intensive care units became the attention of, or was the focus of policymakers' attention, and clearly also of the physicians. And I therefore suggest that we start the debate at the peak of the pyramid with the intensive care, and the very interesting example we heard from Germany presented by Björn Weiss on the ERIC project. It's also dear to my heart. I'm part of the consortium who was leading this project, so I know a fair bit of it. And I understand that my co-moderators, Dimitra and most of all, Florian, that you have some questions collected and added. So please give some questions to Björn, please.
And a very good question that has just come in from Simon for Björn, actually. Is looking at the, well, he calls it the end user of the ERIC program. So really the physicians, the healthcare professionals actually involved with it. So he's asking, how have they, the professionals, really experienced the adoption of the digital technology? And has it met their expectations? Was it below or above the expectations? Could you report a little bit back on that experience, please?
Yeah, that's indeed an interesting question. I would say it was different. It was different. I think the end users, if you want, so the colleagues in the remote site hospitals have mostly been positive about the technology, and when we started, the impression got even better. We did a user survey at the end, which is unpublished yet, and I can tell you that these user survey that was actually led by Reinhard Busse's group actually will confirm that. So it is definitely not negative. I think one big issue, and an issue I think also Reinhard Busse will probably join in, was data protection, of course, and was concerns about data protection when doing telemedicine in general. So this is something you have to overcome, and you have to be very, it even affects the end user. It does not only affect the hospital management level, but it is from the hospital management to the end user that concerns regarding, confidentiality of data, etc., are present. So this is something you have to take into consideration whenever doing something like that. If you consider the patient as an end user, who is definitely somebody who is in the center of telemedicine. I am a big believer in a patient-centered telemedicine approach. I don't like these approaches where you do like WebEx conferences in your offices and looking at pictures, but I really think it should be at the bedside of the patient. The patients like it very much. The patients that were awake and could interact with the robot liked it very much. First of all, we were the only ones not wearing gowns in the COVID pandemic. So they recognized me. Some people in hospitals told me, "Oh, you're the only physician whose face I've ever seen." And that's something good. And they also see very, very fast that there is a human behind the screen, and that we're interacting just like we would do it on a normal ward. So I think the patients are very positive, and it gives them an increased feeling of safety, of being protected in the environment, of having a multidisciplinary big team that also is linked to the university. And so the impression was positive. But this should not, it's important, I don't want to deny or leave out that there are, like, let's say 10 to 15% of end users, if you want to call them like that, people who don't use the technology, who dislike it. Various reasons, but there are people who don't want it, who say like, no, it's not the right thing for us.
Thank you, Björn. Florian, I think you have another question. Yes, let's stay for this topic for a second.
Yeah, and that's actually one that has come in earlier from Alex. So a little bit more on the wider health system implications there, and reasons for the different degrees of maturity of digital health across countries. So Alexo is asking, he's referring to the digital health index that Enrique has showed earlier. He's saying that countries that are more like UK or like the Nordic countries, tax finance, so come more through the beverage system, seem to be more digitalized than those that rely more on social insurance fees, such as Germany or France, for example, with all the differences there might be between within this group. Alexo is asking, is this really the case? So are those beverage countries more advanced in digital health than the other ones? And if it's the case, why could that be?
Whom do you think could answer this question?
I think, well, I mean, you're the health system expert here, Professor Busse, but I'm sure that all experts have something to contribute to that.
And Enrique, you showed this slide, which caused great interest. And I mean, maybe we should say it's coming from the Bertelsmann Foundation, a German foundation. 3 years ago, they looked at various dimensions of the digital health situation. And you showed the map with the overall ranking based on percentages. I mean, maybe we start with Spain, one of the better ranking countries. I mean, how did you feel? Was this a fair judgment, and was it justified?
Well, it was comprehensive. I posted, by the way, the English version of this report. Well, it's not just money. There are, as any other policy reform, there are institutional features that facilitates. For example, a clear point here is that the more fragmented, to me, at least when we're reading through the document, where the more fragmented the health system is, the more complicated to develop a consistent, coherent digital health program or strategy. So, and if is what I tried to highlight in my first slide, that there were some advantages. So if we are 45 million lives in Spain, 99.5 of them are registered. If the vast majority of the healthcare providers, there is single payer system, and all the healthcare providers, primary care, hospital care, the integrated providers are actually obliged to accomplish with the decisions of the single payer. So these are very strong elements to consider as background, as let's say, institutional features that facilitate any reform. And this is another reform. And on the other hand, the Digital Health Index by Bertelsmann Foundation is not about money. Of course, it's important to have a dedicated money to that. In the 2000s in Spain, more than 400,000 million euro were devoted to the development of the digital health program that have aligned in my presentation. But the Bertelsmann Foundation is also considering elements regarding to the political strategy, the governance, the technical implementation. So in terms of resources, but also in terms of skills, of capacity, and also the actual use, whether. And this is I don't remember exactly, but more than 25, 30 different indicators compiled in these big dimensions.
But I think it was overall, I think you can always argue about these indices in general. Yeah. Björn, maybe we turn to you. Germany is one of the countries on the other side, and we saw already a presentation earlier this week on the German Health Innovation Hub and how we are trying to catch up. Maybe your impression. I mean, when we started this ERIC project, this was when this Bertelsmann study was done, which ranked Germany so low. How would you judge, or how would you, from your position, also with the discussions we had with the regional and the federal representatives, how would you judge the speed of catching up in Germany during the Corona time?
Yeah, I'm not an healthcare system expert, but I have this experience, of course, that we are too slowly and that we are always running behind. And that it makes me sometimes crazy that we are so slowly. And I think one big problem that we have is that we are hiding a lot behind data protection. We are hiding behind regulations and rules. And of course, this is a very big problem. And I think digitalization is an important right of patients. Because it is technology that is available and that is improving care. And so I think looking at, let's say, legal frameworks, whether it's data protection, whether it's reimbursement, etc., is important. But we should not forget that the technology and the availability of the technology is indispensable for the success. It is the basis for the success. And if the technology is there, we need to find a way to implement it. And we need an infrastructure that is an infrastructure for data protection, etc., that is actually allowing us to do that. It cannot be the case that we get stuck, or that the whole thing gets stuck with the practitioners. In the end, myself as a doctor has to deal with all these GDPR legal things. We have to invest a lot of money into this. And I think these are barriers that can be overcome because we know it now. And the pandemia, for the first time, I saw that people really wanted the solution and not to admire the problem. They wanted the solution. They just said, because we admire problems a lot in Germany. Maybe it's also, I don't know, maybe it's a socio-cultural thing, but I heard a lot of people that said, yeah, in principle it's possible, but not in the healthcare sector because, the healthcare data, that's very sensitive. You cannot talk about patients of other hospitals. That's difficult. And we need a lot of legal opinions on that, etc. So, I in the pandemia, for the first time, I had the feeling people really wanted the solution and were looking at me and saying, like, how fast can you do that? And I was overwhelmed.
Maybe we turn to you. We saw that Austria in this Bertelsmann study was somewhere in between, so better than Germany, even though we in Germany, of course, think that the Austrians share many of the of these things which Björn just said. But you started earlier, having probably discovered that. Maybe you can share your thoughts with us on this.
Yeah, I just wanted to add, and I agree totally with Björn. I think I can just say it from the Austrian experience. I think it's really hard in Austria also to implement some new solutions and applications throughout Austria. And Austria is a very smaller country compared to Spain and Germany. So if we have the problem here, it might even be bigger in other countries. But this is exactly what I think what Corona has helped us and what the pandemic has helped us, because now we're able to bring up a solution like the electronic vaccination passport and to implement it quite fast. And now the process is already there in the ministries, and I don't know where everything needs to be discussed and the parliament and so on. And so we know the processes now, and we should be able to now repeat the story and add here also new services to our electronic health record system that can citizens in Austria will use in the future. So I think that the pandemic here gave us really an opportunity to speed up the process of implementing new digital health services. And also the citizens in Austria, as Björn said, they want them now. They are aware of them now. They are now more and more familiar with such services. For example, with the 4050 hotline we have here now, everybody knows it now. And I mean, the other problem, as I said before, will be how to go back to the initial service that we were providing. But that's another point. But they are aware of it, and we hopefully can make use of that.
But aren't you also debating that maybe COVID has created too many island solutions? I mean, like the COVID certificate. I mean, I would say as a citizen, wait a minute, why should I now have an app for my COVID immunization? And next time I get a different immunization, it's still in my yellow passport. Why not one immunization solution, which is part of the electronic health record?
But that's exactly the case for Austria. We have this in our electronic health record system, the e-vaccination. So for us, this is was the perfect way to do this. And this is now available. This is one of the sources for the green certificate is the vaccination status out from ELGA. So we are happy with this now.
Björn, you wanted to come in on this?
I wanted to use exactly the same word as you, as saying like that the island solution, and the tethering of the solutions, the fragmentation, and actually the lack of decision for a solution, or at least to offer a market where a solution can prevail or not, that you have some kind of, because look at all of these kind of Corona tracking apps, or look at telemedical solutions. Everybody is having his own technology, everybody is having his own framework. And of course, these frameworks will stay limited. I think we need to think a little bit bigger. At the beginning of the pandemic, Germany did something I think pretty smart. The Health Innovation Hub from the Federal Ministry of Health, they provided a framework for every hospital in Germany to offer telemedical consultations and to have a legal basis for telemedical consultations. They worked together with a law firm. And I think that was a pretty brave step. I'm not fully aware if they knew how brave this really was, but it was good, It allowed people to get their solutions into the market, and it avoided a lot of fragmentation and a lot of anger. It streamlined things, and in the end, the medicine is a market, and there is a medical market, and a solution can either prevail or a solution will end like a startup. And I think the pandemic made this possible. We suddenly had a market for all of this, and we suddenly had competition. If it is oversteered, like for example with a Corona Warn app or things like that, or this digital vaccination passport, then you see what happens. In the end, I don't know what to take, so I have my yellow vaccination passport, and I don't want a digital thing, not because I'm against it, but I simply don't know what to take.
Yeah, but then the solution might not be the nicest one, because we in Austria, we are really using now the app, and we're happy with it, as I said. But you're right, of course, if there are too many for us, we have also some apps coming up in this sector, and then people are unaware of what to use. But I think we need to make clear what the digital solutions are that are in place, and to highlight the ones that we are bringing up as a federation. Yeah.
Teofania has raised the point, right, Dimi, on whether tax-based payment systems are better equipped than social security ones or something. I would like to react to that point. I wouldn't say so, though. Actually, Estonia is not a tax-based, as far as I know, system so far. I think it's more in the design, in the type of how things work, not about how the health system is financed, the key. And the fragmentation is not about tax-based payments, but about just how to organize the care. I think it's a good thing to have clear gatekeeping for many policies. The implementation of complex interventions when you have integrated providers under the same single payer is much easier. But I wouldn't say it's the way you finance the system exactly the big issue.
I think nobody said. I think it's also not the financing. It's more the governance, the steering. And
Exactly.
Enrique, let's come back to the debate of today. I think yesterday, as I said, we talked about information, and I think we had all the feeling the pandemic has helped us, that we will not slow down again with the demand and the demand for more information. I'm already jumping ahead when I say I think tomorrow, when it comes to research, the researchers will not say let's go back to the pre-pandemic era. Today we are in care. And the thing is, how many of these often ad hoc solutions, also supported by otherwise skeptical policymakers and maybe by an undecided public, how many of these new solutions will survive, and how much do we go back to what it used to be before? So does Björn have to remove his Eric Robotas at some stage, or will he be able to use them on different patients not having COVID? I mean, I think that is the main question we are addressing here.
Exactly, and taking that point, well, I think one of the elements here, and I mentioned that, is that there is no clear framework about the added value of this, let's say, digital solutions. We assume that because it's digital, we get fascinated, and this is better, more efficient, more effective by default, and might not be the case. And when it comes to artificial intelligence oriented, many times, most of the times, locked solutions is going to be the same. And there's going to be a surge of apps with artificial intelligence. And my point is that will survive if they pass the threshold of a good evaluation. And we have to make this evaluation possible as soon as possible.
Yeah, I mean, but do you think the public and maybe we also bring in the other ones? I mean, do we realistically think that policymakers will wait until long evaluation reports are available and read them and then
I think
go
there
ahead
is,
or not?
Yeah, no, but I think there is a good experience in NICE, the National Institute for Clinical Excellence, on the assessment and appraisal of artificial intelligence that might take us, well, they humbly say that it's not gold standard, but they say way forward to look at. And I think they have built the methodology, and there is because they are quite aware of the fact that the market is pushing hard, and there are many solutions competing out there, and there is a need for SMEs, and the digital health in the end, the digital economy is there. They are quite aware of that, and they are starting sort of a continuous conversation on the, you know, in the end, the validation of these tools requires in exchange with the system. So this is a, you know, a continuous conversation with the producer of these apps, this artificial intelligence that is needed to take. But at the same time, the producer of this technology has to be aware that if this is not added value, if there is unsupervised by the population, if this is provoke some risks to patients, this has to be in the end evaluated in a formal way.
Of course, but I think we also have to. We heard about the health apps in Germany, which were presented earlier also in the German presentation. And when you now see, I mean, you can prescribe them on the account of the sickness funds, and in total, 30,000 people are doing it. 30,000 of 80 million are using them. Now, then you can debate, is this a success or not, if 1 in 2,500 is doing it or not. And I think that is the thing. The same with Björn. Maybe we come back to you. I mean, how would you envision intensive care in 3 years' time? I mean, is then the telemedicine an accepted option, and but it's only used in, I don't know, 1 in 50 patients, or maybe it's used in 1 in 10 patients, but it's becoming more normal. It will probably not, I mean, it will not replace the physicians. And I think, I mean, but I think we are all here and say, okay, how will this really develop over time?
The question is good, and the question, I would say, I completely agree with Enrique that we need to evaluate concepts, and that we can only implement concepts that have a clear signal towards an improved treatment of patients or whatever we want to achieve with it. And the question is, of course, a little bit unfair, because we know the results of the ERIC project, and without going too far, we can say, I think we can say that it was a success, that this technology is improving things. And we see that on an everyday basis, on a qualitative basis. For intensive care, I would say it definitely makes sense. You know, intensive care in Germany is, we have a big intensive care sector. We have an aging population. We have a lot of challenges in the future. We have a lot of hospitals. We have a lot of intensive care units, and they are not linked to each other in some meaningful way. We are working with fax machines. We are working with telephones. We are working sometimes in really medieval conditions. And I mean, using new technology, using robots, making the whole care a little bit more streamlined, that's important. But it requires, of course, in the future, more than just having the robot and, a generous funding institute that says, okay, yeah, we are going to give you one more million and another more million. It requires actually also the reimbursement of the healthcare system and of intensive care in particular, because this is what I'm doing, to be aligned with that and to say, okay, this quality that is added is also leading to some kind of incentive, or on the other hand, is leading to some kind of restriction if you don't have it. I think this is a very important point, and I would go so far to say that, you know, the healthcare system also has at least to adapt a little bit to the newer technologies and to also make it really a standard of care and not see it as some kind of, you know, future robot going to an intensive care unit. But they have to say, okay, we have the technology and we use the technology. And knowledge transfer, and you know, we do nothing more but knowledge transfer from a university, from an academic hospital to small and medium hospitals. That is a very important column of healthcare in the future. And I would say, all the technologies, the new dialysis machines, the ECMO machines, the ventilators, all these fancy stuff, they get reimbursed pretty quickly. It's a matter of 1 to 3 years, then you get reimbursement for a new filter for the dialysis machine. But for knowledge transfer, for having like super experts taking care of super sick patients, that's something where we still believe a little bit in this kind of religious magic that a doctor in a hospital has the right to treat, to have an autonomous treatment. And I think this requires a cultural change, and cultural changes usually don't happen in 2 years. But I hope that in 10 years, people will laugh about these questions.
Okay, Katrin, any remarks from Austria? Maybe not on intensive care. We know that you're also working on primary care. Maybe you did the two things come together. How you strengthen primary care and the role of digital health in healthcare.
Just can again agree to what Björn said. I think it will require also a cultural change, behavioral change, as I also mentioned in my presentation. People not only need to have the possibilities, but it needs to be financed. This is also what Björn said. Then it will be easier to adopt new services and solutions. Now I think we have the momentum on our side to show people the solutions, and hopefully they will use it. And also the trust is a big topic there. Trust in those solutions and trust what we are offering. So there are different kind of aspects we need to have on our radar and we need to work on. So hopefully, as Björn said, we will be able to look back in 10 years and laugh that people were not aware of robots running around in hospitals and so on. So I'm hoping this will be the near future.
Good final words here, Florian. Dimi, do we have another one on the one? Maybe we can take one more interesting question.
Sure. One that has come up also, and I think it's the right time not to ask, is regarding the reimbursement scheme that we have seen and the changes there at the Commission's level. So one going out here is, to what extent was the role of changes in payment for digital health solutions also very critical in stepping up digital health across the EU? And to what extent can this remain sustainable potentially post-pandemic?
Fiona, I've seen your hand and it's about Europe, so please go ahead.
Well, I'm not really sure that we have a reply to all the aspects that are very relevant for this. It is clear that the reimbursement is absolutely key. Just to give you an example, for instance, for the rare disease patients, we have an IT system which allows the consultation between the healthcare professionals to discuss the complex cases. It's called the Clinical Patient Management System. But unfortunately, neither the regulation, Social Security Coordination, or the directive, Patients' Rights Directive, allow for a clear reimbursement of this kind of digital solution. We are now in the process of reviewing of evaluating the Patients' Rights Directive, and probably this will be one of the issues that will be clearly on the agenda. There is also, still in the context of the cross-border aspects, the possibility of reimbursing purely digital solutions without necessarily the provision of the healthcare for the patient. And still, this is not very, very clear. Normally, what we are paying through our normal and traditional instruments, Regulation 883 or the Directive 2011-24, are the physical consultation of the patient. If it is linked with the digital follow-up afterwards, digital monitoring could be part of the prior authorization and could be reimbursed. But if it is separate, it's much more complicated. And this is something that we should clearly take into account. And the other point also nationally, and in which we are looking with a lot of interest, is how we can support also the digital solution, but not only this, also the interoperability, the quality, etc., also in the context of the European health data space, and how, for instance, these elements could feed into the decisions of HTA bodies when they are doing also their evaluations for reimbursing. Because if we are paying, if we are reimbursing, someone was saying that the digital solutions are not a miracle. Clearly they are not. And what we are also saying that in many cases, they can raise issues related to interoperability. So if we are creating silos, then they can be a real issue. But if we are making sure that basically the data can flow and the data can be used, then basically the patient can also decide what to be in control of these data, they can be a real added value for the health of the patients, for the work of the professionals, etc. But this also means that all these aspects related to the quality, interoperability, security, privacy, etc., they have to be taken into account from the outset, and they also have to be looked at from the reimbursement perspective. And there was also the discussion about the type of systems, but I think there is also a catch-up, for instance, from the side of France, Germany, etc. And just to give an example, for instance, the DIGA system in Germany, it's quite forward-looking and quite an opener of way of looking at digital solutions in an integrated way, and also how to make it part of the everyday work of the patient, everyday life of the patients, and everyday work of the healthcare professionals, but how to take also the other aspects into account, like impact on health and interoperability, security, etc., etc. So these are elements that cannot be dissociated. And with the European health data space, we are also looking how all these elements can be brought together and how different institutions, digital health, HTA, medical devices, bodies, can and should work together, and also, of course, patients and healthcare providers associations can work together in order to make sure that basically the impact of the digital solution is really maximized. And we are not just creating gadgets, but we are really bringing tools that are useful for the patients and for the doctors in their work.
Yes, thank you, Iona, for putting this in this broader picture, because we have not, in the pan-European view, we have to disentangle, I mean, telemedicine, if the patient is in one country and the telemedicine provider is in a different country, and then who is responsible for aftercare. You mentioned health technology assessment. In one of the last live summer schools, we debated the European movement towards joint assessments. Now it's coming forward. It looks like clearly digital health will be, besides the drugs and the medical, the classical medical devices will be the third area probably where we need to discuss that, even though it's not as explicitly mentioned in the directive there. All these interesting topics. To some of them we will return in the Friday session. But before we have the Friday session, we have the Thursday session, which will be tomorrow, and there we will be looking at the impact of the role of digital health on research. And I think this is also where we saw exciting and quick changes during the corona pandemic. And I think we can all look forward to tomorrow's session. But before we now close, let me thank again all the speakers of today. Joanna from the Commission, Björn from Germany, Catherine from Austria, and Enrique from Spain. I think we again got very good examples how these exciting times are shaping our health systems and how digital health is part of these big changes. And we all hope to see you back tomorrow and then on Friday. Have a good rest of the afternoon, and bye-bye.